What's up everyone, and welcome to the Dr. Hayatu medical channel. It's an honor to have you here. In the fast-paced, high-stakes world of emergency medicine, having the right tools at your fingertips isn't just important. It can be the difference between life and death. As clinicians, we train for years to handle these critical moments, but our knowledge of pharmacology, specifically emergency medications, is one of our most powerful assets. When a patient is crashing, there's no time to consult a textbook. You need to know what to give, how much, and why, almost instinctively. In this video, we're going to break down 10 of the most essential, life-saving emergency medications that every single clinician, whether you're a medical student, a new resident, or a seasoned attending, absolutely needs to know inside and out. We're not just going to list them, we're going to dive deep. We'll cover the specific indications, the correct dosing and routes of administration, and most importantly, the practical application of these drugs in real-world emergency scenarios. This is the kind of high-yield, no-fluff information that builds confidence and competence when it matters most. My goal here is to create a resource that you can come back to, something that solidifies this critical knowledge so you're prepared to act decisively when the pressure is on. We'll walk through each medication step by step, exploring the mechanism of action and the real-world impact it has on a patient in distress. This isn't just about passing an exam. This is about being the best clinician you can be for your patients. So, grab your notebooks, get focused, and let us begin. First on our list is the king of emergency meds, adrenaline, also known as epinephrine. This is your go-to drug in some of the most critical situations you'll ever face. Think anaphylactic shock, cardiac arrest, and life-threatening asthma. In anaphylaxis, a patient's airway is closing, and their blood pressure is plummeting. You need to act fast. The dose is 0.3 to 0.5 milligrams intramuscularly in the thigh. This powerful drug works by constricting blood vessels to bring up blood pressure, reducing swelling in the airway and stimulating the heart. It's truly a multi-system lifesaver. In a cardiac arrest scenario, the game changes. Here, we're using adrenaline to restart the heart. The standard ACLS protocol calls for 1 milligram administered intravenously or intraosseously every 3 to 5 minutes. This dose helps to increase blood flow to the heart and brain during CPR, making defibrillation more likely to be successful. For severe asthma that isn't responding to standard treatments, a subcutaneous or even nebulized dose can provide potent bronchodilation, opening up those constricted airways. Understanding these different contexts and doses for adrenaline is absolutely fundamental for any clinician. It's a powerful tool, and knowing how to wield it correctly is a massive responsibility. Next up, let's talk about atropine. This medication is your primary weapon against symptomatic bradycardia. That's when a patient's heart rate is dangerously slow, causing symptoms like dizziness, fainting, or chest pain. The vagus nerve, a key part of the parasympathetic nervous system, acts like a brake on the heart. Atropine works by blocking this brake, allowing the heart's natural pacemaker to take over and speed up the rate. The standard dose for bradycardia is 1 milligram intravenous push, which can be repeated every 3 to 5 minutes up to a total dose of 3 milligrams. It's crucial to recognize when bradycardia is causing instability and requires immediate intervention. Atropine also has a critical, albeit less common use as an antidote for organophosphate poisoning. This can happen from exposure to certain pesticides and nerve agents. These toxins cause a massive overstimulation of the parasympathetic system, leading to the classic sludge symptoms: salivation, lacrimation, urination, defecation, GI distress, and emesis. In these toxicological emergencies, much larger doses of atropine are required, often 2 to 4 milligrams intravenous or intramuscular initially, with repeated doses until the patient's secretions dry up and their heart rate improves. It's a classic example of using a drug to counteract a specific poison, and it's a lifesaver. In today's world, every clinician must be intimately familiar with naloxone, often known by its brand name, Narcan. This is the definitive antidote for opioid overdose. When a person overdoses on opioids like heroin, fentanyl, or prescription painkillers, the most life-threatening effect is respiratory depression. Their breathing slows down and can stop completely. Naloxone works by being an opioid receptor antagonist. It has a stronger affinity for these receptors than the opioids themselves, so it literally kicks the opioids off the receptors and reverses their effects almost instantly. It's incredibly dramatic to witness. The dosing and administration are designed for rapid use, even by non-medical personnel. It can be given intravenously, intramuscularly, subcutaneously, or, most commonly in the field, as an intranasal spray. A typical starting dose is 0.4 to 2 milligrams. The key is to give just enough to restore adequate breathing, not necessarily to fully wake the patient up, which can precipitate severe withdrawal. Because many opioids, especially fentanyl, are long-acting, and naloxone is short-acting, you may need to re-administer the dose. Continuous patient monitoring is absolutely critical after giving naloxone, as they can slip back into respiratory depression once it wears off. Now let's discuss diazepam, which is actually a member of the benzodiazepine family. Its primary emergency use is to stop active seizures, a condition we call status epilepticus. You see, a seizure is kind of like an uncontrolled electrical storm in the brain, and status epilepticus is a true medical emergency that can cause permanent brain damage or even death if not stopped quickly. Diazepam works by enhancing the effect of a neurotransmitter called GABA, which is the brain's main inhibitory, or calming, chemical. By boosting GABA's effects, diazepam effectively dampens that excessive electrical activity and, well, terminates the seizure. The dose and route you use will depend on the situation. In a hospital setting with intravenous access, 5 to 10 milligrams of diazepam can be given slowly through an IV. But in a pre-hospital setting, or if IV access is tough, it can be given rectally as a gel, which is absorbed very quickly. Beyond seizures, diazepam is also used for managing severe agitation or acute alcohol withdrawal, where its sedative properties can help keep both the patient and staff safe. It can also be helpful for severe muscle spasms. It's a pretty versatile sedative, but like all benzodiazepines, it can cause respiratory depression, so you must always be ready to support the patient's breathing, especially when giving it intravenously. Hydrocortisone is a corticosteroid, and honestly, it's a workhorse in several emergency situations where inflammation is the main enemy. One of its key uses is in anaphylaxis. Now, while adrenaline is the first-line immediate lifesaver, hydrocortisone plays a crucial secondary role. It works by suppressing the immune system's inflammatory response, which helps prevent what's called a biphasic or late-phase reaction. This is where symptoms can actually recur hours after the initial allergic reaction seems to have resolved. The typical intravenous dose is 100 to 200 milligrams, and it provides a sustained anti-inflammatory effect that adrenaline just doesn't offer. Another critical indication is an adrenal crisis. This is a life-threatening condition where the body just can't produce enough cortisol, which can lead to a catastrophic drop in blood pressure and shock. This can happen in patients with known adrenal insufficiency who are under stress from, say, an infection or surgery. In this case, giving stress-dose steroids like hydrocortisone 100 milligrams IV is not just helpful. It's actually life-saving replacement therapy. It's also used in managing severe asthma exacerbations and status asthmaticus, where its powerful anti-inflammatory effects help reduce airway inflammation and mucus production, working alongside bronchodilators like salbutamol to open up the airways. Let's move on to furosemide, which is commonly known by the brand name Lasix. This is a potent loop diuretic, and its main job in an emergency is to get rid of excess fluid and to do it fast. The classic indication is acute pulmonary edema, which is often caused by heart failure. In this condition, The lungs are literally filling with fluid, causing the patient to feel like they're drowning. They're short of breath, hypoxic, and extremely distressed. Furosemide works on the kidneys, specifically the loop of Henle, to block the reabsorption of salt and water, forcing the body to excrete large amounts of urine. By rapidly pulling fluid out of the system, furosemide reduces the volume of blood returning to the heart, which in turn lowers the pressure in the blood vessels of the lungs. This allows the fluid to move out of the lung tissue and back into the circulation, which dramatically improves the patient's breathing. The typical starting dose is 20 to 40 milligrams IV, and that can be doubled if there's no response. It's also used in other states of fluid overload. However, you really have to be cautious. By removing fluid, it can drop blood pressure and deplete electrolytes like potassium, so careful monitoring of vitals and labs is essential. Salbutamol, or as it's called in the United States, albuterol, is a medication that every clinician will, use quite frequently. It's a fast-acting beta-2 agonist and is really the first-line treatment for those acute asthma attacks and exacerbations of chronic obstructive pulmonary disease, or COPD. In these conditions, the small airways in the lungs, known as bronchioles, go into spasm and become narrow, which makes it incredibly difficult to breathe. Patients will typically present with wheezing, shortness of breath, and coughing. Salbutamol provides rapid relief by directly targeting and relaxing the smooth muscle that lines these airways. The most common route of administration is through a nebulizer or a metered dose inhaler, or MDI. In a severe attack, a continuous nebulized treatment might be necessary. The standard nebulized dose is typically 2.5 to 5 milligrams, and it can be repeated every 20 minutes for the first hour if needed. By stimulating beta-2 receptors in the lungs, it causes bronchodilation, opening up the airways and improving airflow almost immediately. While it's incredibly effective, it can have side effects like an increased heart rate and tremors, as it can have some mild effects on beta-1 receptors in the heart. It's really a cornerstone of respiratory emergency management. Shifting gears to infectious diseases, let's talk about cefteraxon. This is a powerful, third-generation cephalosporin antibiotic, and honestly, it's a go-to choice when you're faced with a patient with a suspected severe, life-threatening bacterial infection, and you don't yet know the specific culprit. Think of conditions like severe sepsis or septic shock, bacterial meningitis, and severe community-acquired pneumonia. In these situations, time is tissue, and early administration of a broad-spectrum antibiotic that covers a wide range of likely bacteria can be life-saving. Cefteraxon is valued for its excellent coverage against many common gram-positive and gram-negative bacteria. For sepsis or pneumonia, a common dose is 1 to 2 grams IV once or twice a day. For suspected bacterial meningitis, we use a higher dose, typically 2 grams IV every 12 hours, because it penetrates the blood-brain barrier well. The principle of time to antibiotics is a core tenet of sepsis management. Delaying the first dose by even an hour can significantly increase mortality. Cefteraxon allows you to provide powerful, effective coverage right from the start, while you wait for blood cultures and other diagnostic results to come back and guide more specific therapy. This next one is simple but profoundly important. Dextrose. Dextrose is just a form of glucose or sugar, and its emergency use is to treat severe hypoglycemia. A dangerously low blood sugar level is a true medical emergency because the brain relies almost exclusively on glucose for energy. Without it, brain cells can start to malfunction and die, leading to confusion, seizures, coma, and permanent brain injury. This can happen in patients with diabetes who have taken too much insulin or in other rare conditions. Recognizing and treating it quickly is paramount. If the patient is awake and able to swallow, you can give them oral glucose. But in a patient who is unconscious or unable to protect their airway, you need to give it intravenously. The standard treatment is an ampule of 50% dextrose, which contains 25 grams of glucose, given as a slow IV push. You will often see a dramatic improvement in the patient's mental status, literally, as the dextrose is going in. It's honestly one of the most satisfying interventions in emergency medicine. Always remember to check a fingerstick glucose on any patient with altered mental status. It's a simple test that can uncover this easily reversible, life-threatening condition. Last but certainly not least, we have normal saline. It might seem basic, but intravenous fluids are one of the most fundamental and life-saving interventions we have. Normal saline, which is a solution of 0.9% sodium chloride in water, is an isotonic crystalloid fluid. This means it has a similar salt concentration to our blood, so when you infuse it, it stays in the intravascular space and rapidly expands the volume of circulating blood. Its primary use is in treating shock, which is a state of inadequate tissue perfusion. This is most commonly seen in hypovolemic shock from blood loss or dehydration, and in septic shock, where blood vessels become leaky. In a patient who is hypertensive and tachycardic from dehydration or sepsis, the treatment is aggressive fluid resuscitation. This often involves giving a bolus of fluid, typically 500 milliliters to 1 liter of normal saline, infused rapidly over 15 to 30 minutes, and then reassessing the patient's response, their blood pressure, heart rate, and urine output. The goal is to restore the intravascular volume, which improves blood pressure and ensures that vital organs like the brain, heart, and kidneys are getting the oxygen and nutrients they need. While other fluids like lactated ringers exist, normal saline is the ubiquitous, essential fluid for initial resuscitation in countless emergency scenarios. And there you have it, 10 essential emergency medications that form the backbone of modern resuscitation. From restarting a heart with adrenaline to reversing an overdose with naloxone, these drugs are powerful tools that, when used correctly and promptly, can genuinely save lives. Mastering them isn't about memorizing facts for a test. It's about building the deep, practical understanding that allows you to act with confidence and precision when a human life is on the line. Every emergency is a high-stakes performance, and these medications are a critical part of your script. Remember, the principles of patient safety are paramount. Always assess the patient thoroughly, confirm the indication for the drug, double-check your dose and route, and then monitor the patient's response closely. Medicine is a team sport, so communicate clearly with your nurses and colleagues. These 10 medications are your allies in the fight against critical illness, but they demand respect and careful handling. Continue to study, continue to practice, and never stop learning. Your patients are counting on you to be prepared for their worst day. I hope you found this deep dive helpful and that it serves as a valuable resource in your clinical journey. If you learned something today and want to see more practical medical education like this, do me a huge favor and hit that like button. Share this video with your colleagues and friends in healthcare. And of course, subscribe to the Dr. Hayatu Medical Channel so you don't miss our future content. Your support means the world and helps us continue our mission. Thank you so much for watching, and stay sharp.